Welcome to the Deep Dive. Today we're tackling one of the most urgent and frankly one of the most distressing topics we've ever covered. We're focusing on the Black maternal health crisis in the United States.
That's right. And we've got a lot of sources here, research papers, historical accounts, and our goal is to really unpack why this is happening. We want to trace it from its roots all the way to what's happening in hospitals right now.
And let's just state the central non-negotiable fact right at the top.
Yeah.
This crisis Black women are facing, it's driven by systemic factors, by deeply embedded racism.
Exactly. It is not about any kind of inherent biological vulnerability. That's a myth we have to dismantle from the start.
Okay, so let's start with the numbers because they really frame the magnitude of this.
They're horrifying. The latest CDC data confirms that Black women are between 2.5 to 3.5 times more likely to die from pregnancy-related causes than white women.
Wow.
And to put a really fine point on it, in 2021, the rate for Black women soared to around 70 deaths per 100,000 live births. 70, and for white women, it was about 27 per 100,000.
So 70 versus 27, I mean, that gap, it's not just a statistic. It tells a story of two completely separate standards of care.
It absolutely does. It represents thousands of preventable tragedies.
You know, when people hear about health disparities, I think the first assumption is often about money, about socioeconomic status, lack of insurance, that sort of thing. The idea is if you do everything right, you'll be safe.
And that's the crucial finding that just completely dismantles that myth.
Okay.
This crisis is not resolved by class or success. The research is clear. Socioeconomic factors have very little impact on these mortality rates for Black women. They suffer poor outcomes regardless of their income or education level.
That is so hard to process.
Yeah.
It means you can be a doctor, a lawyer, an executive with the best private insurance, going to the best hospital, and you're still not safe.
Your safety net isn't there because it's not about access to resources. It's about the quality of care you receive and the biases of the providers you encounter.
And this is where the data gets really, really interesting
Yeah.
and just painful.
Mm-hmm.
There's this one astonishing example about pain management. Research showed that privately insured Black women got less epidural pain relief during labor than uninsured white women.
Uninsured. That right there, it strips away every excuse. It's not about money. It's not about insurance.
It's about bias.
It's about a pattern of what researchers formerly called disrespectful and abusive care, or DNA. And this isn't just a bad bedside manner. We're talking about harsh language, dismissing a patient's pain, and just overt racism.
So these traumas women experience they're directly linked to them being seen as Black women.
Inextricably linked, yeah. They're perceived through this historical lens that says they're less sensitive, less credible.
We have to trace that perception because it didn't just appear out of nowhere. This goes way back.
It goes all the way back to slavery. I mean, this foundational, completely false idea that Black people are biologically different.
That they have thicker skin or a higher tolerance for pain.
Exactly. It was literally manufactured to justify brutal exploitation, and then it got institutionalized in medicine. And the most notorious figure here is J. Marion Sims.
The so-called father of modern gynecology.
That's him. In the 1840s, he performed these brutal experimental surgeries on enslaved Black women. We even know their names: Anarcha, Betsy, Lucy Zimmerman. He was perfecting procedures like fistula repair.
And he did these operations repeatedly, dozens of times on the same woman with no anesthesia.
Right. Even though things like ether were starting to become available, he justified it with these racist theories, claiming Black people had an obstetrical hardiness or a primitive pelvis. It was pseudoscience to cover for torture.
But his own notes contradict that, don't they? He wrote about Lucy Zimmerman's surgery, and he admitted her agony was extreme.
He did. He wrote that he thought she was going to die on the table. He saw the suffering firsthand.
But it didn't change anything.
No. His belief system was so rigid, he just kept denying anesthesia to his Black patients, even when it became standard for his white patients. And that history, it set this precedent that Black pain isn't real, or at least isn't worth treating.
And that's the truly chilling part. That ghost is still in the machine. It's still haunting modern medicine.
It is the direct connection. I mean, there was a landmark study in 2016 that found that about half of white medical students and residents surveyed still held at least one false biological belief about Black people. Half. Things like Black people having thicker skin or less sensitive nerve endings.
So you have doctors walking into a delivery room today who are pre-programmed to believe their patient feels less pain. And that assumption just It infects every decision they make.
Absolutely. And that is how you get this modern disrespectful and abusive care. It's how you get the dismissal of concerns, the dismissal of pain. Patients are labeled dramatic or just ignored.
And we have some really high-stakes anecdotes that show just how dangerous that can be.
Yeah, these aren't minor incidents. We're talking life and death.
There's that viral video, a Black woman in very advanced labor, clearly in agony, calling for help.
And a nurse just walks right past her, ignores her completely. She delivered her baby just 12 minutes later. That's abandonment.
And sometimes it leads to these near-fatal outcomes. We have a story of a mother who was bleeding heavily after giving birth. She knew something was wrong.
She kept telling the doctors and nurses she knew it wasn't normal.
And they just dismissed her, said it was normal.
Bleeding is normal after birth. They just left her alone, disregarding her knowledge of her own body.
She had to keep pressing the emergency call button over and over until she actually passed out on the floor. She nearly bled to death before they finally took her seriously.
And that delay is a direct result of a provider choosing their bias over the patient's own testimony.
It's not just postpartum either. We hear about women being told their water breaking is just them peeing their pants, or it's discharge.
Right, and those delays lead to dangerous emergency C-sections because care was put off for so long.
So you're in this constant battle to be seen as credible right when you're at your most vulnerable. And then on top of that, there's the assumption of drug seeking.
It's so pervasive. There's this one account of an upper-middle-class Black woman. She's in active labor, 7 centimeters dilated, and the nurses just keep questioning her about drug use.
And then what happened?
Her husband, who is white, walked into the room.
And I'm of guess. The tone changed.
Instantly. The questioning stopped. The staff became kinder, more attentive. His presence validated her pain in a way she couldn't on her own.
The emotional toll of that, having to fight the people who are supposed to be saving you, it's just immense.
It is. Women report being told to close your legs or being called lazy. You're forced to become your own fierce advocate while you're navigating this incredible physical trauma.
Which brings us to this really strange, toxic contradiction. Black women seem to be simultaneously over-medicalized and medically neglected.
It's a paradox, and it's rooted in those same racist beliefs. The over-medicalization is clearest when you look at C-sections. Black women have a significantly higher rate.
About 36%, right, compared to 31% for white women.
Exactly. And this also has historical roots, with experiments on enslaved women going back to the 1830s. Today, that disparity persists because Black women are just not listened to when they push back against surgery. Their autonomy is ignored.
And a C-section isn't a minor procedure. A study found it accounted for an extra, nearly 16% of maternal morbidity in low-risk Black women. So they're being pushed into a riskier procedure.
And then comes the neglect. The part where they're seen as impervious to pain.
So after the major surgery, they may not have needed.
Studies confirm it. Black women report the highest levels of severe pain after a C-section, but they're checked on less often and they receive less pain medication than white women. It's the worst of both worlds. Unnecessary surgery followed by unnecessary suffering.
And what about consent? We heard stories of women who had to ask if their surgery had already started.
Yes. Just a total breakdown of communication. Patients reported feeling like they were being practiced and played on by residents without any real consent.
That's horrifying. To realize they're already cutting into you because no one bothered to speak to you.
That violation of dignity, on top of everything else, it just reinforces this deep fear of the medical system. It's a process that feels designed to strip away your agency.
Okay, so we've traced this from, the 19th century all the way to a modern delivery room. The crisis is systemic, it's rooted in these false beliefs, and it shows up today as dangerous disrespect. So where do we go from here? What's the path forward?
Well, the solution has to be structural. We have to recognize that racism, not race, is the root cause. So interventions have to be aimed at promoting respectful care, changing policies, and actively reducing implicit bias in providers.
You hear a lot about bias training, but it seems like it hasn't fixed the problem. Does the solution have to be more than just, a required online course once a year?
It requires radical change and accountability. It's not just about changing hearts, it's about changing systems. For example, just implementing basic guidelines for respectful maternity care. Things like effective communication, introducing staff, explaining procedures.
The basics of human dignity.
Exactly. Those simple things have been shown to drastically increase trust. When the system enforces communication, it takes away the provider's ability to rely on their silent bias.
That emphasis on dignity and trust is so key. And that leads us to a final provocative thought for you to explore on your own.
Mm-hmm.
We know that black newborns die at 3 times the rate of white newborns. A horrible statistic. But that disparity is reduced by 58% when those babies are cared for by black physicians.
58%. It's an incredible number.
So given that undeniable evidence, what is the true cost to public health, not just for mothers, but for infants too, when our medical system consistently fails to train, retain, and support a diverse and truly unbiased workforce?
That is the question that should be driving policy and action long after this deep dive is over.
Thank you for joining us for this crucial deep dive.